Good afternoon again. I'm going to try to do two 10-minute talks in 10 minutes. Basically, the first one deals with Ventana, and I have nothing to disclose there. You might want to read this. This is proprietary information from the company, and it has to do with the whole Ventana system. Basically, fenestrated EVARs were developed to address some unmet needs. The unmet needs were inability to deal with short necks, highly angulated necks, or pararenal or juxtarenal aneurysms. And what the fenestrated device does is extends the seal zone above the level of the renal vessels over a distance of approximately 15 millimeters or a centimeter and a half to just below the SMA. And it's ideal for short necks and angulated necks. As I mentioned, you can see 8 millimeter, 2 millimeters, 1 millimeter, and no neck at all. The Ventana fenestrated system is a preloaded system that has a scallop for the superior mesenteric artery, and then it has two fenestrations that are placed in appropriate locations for the renals. And then there's a whole raft of delivery components that go through a delivery system that manages the access to the renal vessels, puts the fenestrations in the right place, and then actually stents the renal vessels. The rest of the device is just a standard Endologix lower AFX bifurcated device that sits on the aortic bifurcation. This is the inside. This is how this customization works. The fenestrations are in this material, which actually moves. It is not attached to the endoskeleton of the device. And that lets you move that fenestration around to line it up with the renal vessels relatively easily. As long as you get the scallop around the SMA, and there's a pretty wide for that, you can see how that moves and allows you to locate this device right over the renal vessels. And then there are some pushers. There are pushers that go in and actually push that fenestrated area into the orifice of the renal arteries. And once the fenestration is pushed in the right place, the preloaded cannulas and guide wires go through and go into the renal vessels, and the rest is relatively straightforward. I think you've seen some slides on this earlier. You can see on the right-hand side where the guide wires go into the renal arteries, and from there it's just a matter of putting the stents in and completing the deployment of the device. The Ventana CE trial studies, this is one case, pre-op, basically a no-neck device, and as you can see, the post-op result at 1 month looks very good. Here's another 6.2 centimeter aneurysm, a juxtarenal aneurysm, again, relatively simple to manage if you have the technical skills to do with it. If you look at the enrollment for this study, the pilot was 15, feasibility study was 30, which was used to submit for the CMARC, and then there's an IDE study in progress in the USA. 75 or 76 have been enrolled out of a total of 122. The CMARC studies, you can see, they were done in New Zealand and Chile, Paris, Cleveland, Los Angeles, and Indianapolis. And the technical success here was really quite good. They need to be followed out for about 5 years. The key points in patient selection: the aneurysm needs to be greater than 5.5 centimeters in diameter or equal to it. You need access anatomy to get the device in through the iliacs. It's a 18 French system. You need a neck less than 15 millimeters, and the distance between the SMA and the renals needs to be 15 millimeters or more, and the diameter in that area needs to be between 18 and 34 millimeters. The rest is fairly, you need to have a serum creatinine of less than 2. And if you look at the numbers here, I think the important things here, the infrarenal neck in the study that went for the CMARC was 6.9 plus or minus 3 millimeters. And the fluoroscopy time to get to renal cannulation was 23 minutes. But look down a little ways and you'll see the overall fluoroscopy time was 52 minutes for the procedure. Mind you, this is a fairly straightforward system. The in-hospital mortality was none. You look at the comparable series here, you look at Ventana at the bottom, there was basically no 30-day deaths compared to some of the others. Target vessel patencies, 94%. The ones that weren't were involving the renals. And you look at the post-op renal dysfunction, still relatively low. But because of that, the company has suspended the FDA IDE in the United States with 76 patients enrolled, and they're undergoing a root cause evaluation to determine if anything needs to be changed with respect to the renal stents and the renal delivery system. All in all, though, the performance of the device has been as expected with that notable exception. That's all I have on that. Let's go to, can you put the next one up for me, please? It's EVAS.
Dr. Buckley is going to do the second part of his talk on the new NELIX system, a sac sealing EVAR system. And I think that you've been, Cliff, one of the first operator to use this very innovative system. It's something that you need to explain to us.
No, this is not right. This is not mine.
Can you put the second part of the talk of Professor Buckley, Cliff Buckley, on NELIX? He got two talks in one, two talks
That's
in
it.
one.
This is it right here.
Okay, let's go.